Thank you, Dr. Rupak, for this invitation and good morning. So I'll just be showing some videos of nucleus drop and IOL drop. So when you've had a nucleus drop and usually the anterior segment surgeon refers the patient to the VR surgeon, and often we don't get a complete description as to what was the extent of nucleus drop, and it's difficult to really say, but as you can see in this case, it's a complete nucleus which is lying on the posterior pole. So creating a PVD and removing the vitreous is the first thing that needs to be done, and you can see that this is a fairly hard cataract, so we'll need phacofragmentation. So the wide angle visualization systems are very helpful in this case, because once you're creating a PVD, you can watch the vitreous go into the periphery and see for any iatrogenic breaks that you might be creating. So once the vitreous is completely removed, then you can enlarge one of the incisions on the constellation. We still don't have a 23 gauge or a 25 gauge fragmentome. So one incision has to be enlarged to a 20 gauge one, and then once you've introduced the so there you can see that one of the incisions is enlarged, and then with the suction the nucleus is lifted into the anterior and mid vitreous cavity, and then it is emulsified. So often this is another thing that you see, that you can see that the nucleus rides up on the shaft of the phacofragmentome, so you have to use the light pipe to push it down and keep kind of supporting it, and use it as a kind of a second instrument, feeding it into the phacofragmentome tip. So the key is that do not do this process near the retinal surface, do it in the anterior or the mid vitreous cavity. And once you've created a few cleavage planes and you've eaten up on the part of the nucleus, then you get these edges which are then helpful to kind of move ahead. So there you can see that now those small pieces are remaining. And very small fragments you can even remove with a cutter, provided they are not very hard, and you can see that the complete removal has been done. So in this case scleral fixation of IOL was done, and so these are some pictures of how we would see these patients referred to us with lot of cortical matter in the anterior chamber, and this is how they look post operatively. In this case PCIL was implanted in sulcus. Now I'll just show you another video of a few videos of dropped IOL. So this in this case actually it was a complicated cataract surgery with aphakia, and I'm just doing the complete cleanup of the anterior chamber and then doing a scleral fixation of IOL. I do a 2-point fixation. And the advantage of a constellation machine is that because of the IOP control, even despite going for a regular limbal incision, the IOP does not drop. So with gradual tugging of the sutures on either side, and I'm transfixing it with a 10-0 proline suture. On one side is a curved needle, and on the other side was a straight 10-0 proline suture needle. So this is how it looks post operatively. This is actually a case of subluxated lens in a younger patient, and we with the MVR first we make an entry into the lens and see how hard it is, and this is with one port closed. You can depress and remove the cortical matter and the capsule from the this patient underwent a scleral fixation. This is a case of dropped IOL, you can see on ultrasound B scan. So this is an older video, so it's a traditional 20 gauge surgery. You can lift this IOL with a passive suction of the flute needle, bring it anteriorly, and with the handshake maneuvers Just transfer the grip to the instrument in the other hand. And then explant the IOL. Liberally using viscoelastic to protect the endothelium. Sometimes with a smaller pupil it's a little bit of a struggle because the iris tends to prolapse. And this is post-operatively. This again, a scleral fixation was done with nicely buried suture. This was a case of totally dislocated IOL with the bag, and you can see it's lying on the posterior pole with extensive myopic chorioretinal degeneration there. I am trying to grasp it with an end gripping forceps, but not able to do so, and with the very thin retina underlying, it's kind of scary. So I grasp it with the capsular bag and bring it anteriorly. And this was a foldable IOL, so I will just try to remove it without making an incision, a large incision, and by just cutting the IOL almost all the way and then rotating it out, as you shall see soon. So this time the handshake maneuver is to an instrument which is introduced from the limbus. It's a vitreoretinal forceps which was introduced from the limbus, and exteriorizing one haptic after enlarging the incision. And then I just placed a suture to prevent the IOL from accidentally falling back. This was just a kind of an improvisation, as you will see now. Now cutting the IOL with the vanners. And then just pulling it out one half first and then rotating it. The capsular bag will be stripped now. You will see that the capsular bag comes off now. And then after rotation, the other half of the IOL is taken out. So in this case, this was a post-op recovery, and we left the patient aphakic because of the extensive myopic chorioretinal degeneration. There was hardly any IOL power. Sometimes you can use the same IOL and you need not put in a fresh IOL. In this case, the IOL explanted is put back into the sulcus. If there is a residual rim which is sufficient enough and stable, you can use the same support for introducing the same IOL, as you can see here. Also, you can sometimes hang if it's a 3-piece IOL, you can hang the IOL from the iris and then later on make the incision and take out. This is another technique which is used, but this is not possible with a single piece IOL. And then sometimes you can use an AC IOL for the rehabilitation of this patient. Not in all cases do you need to go from pars plana. In this case, the dislocation was not that significant and the residual support was sufficient, and the same IOL was dialed back into the sulcus. So I have just one more video to show you. So this was a case of SF IOL, the scleral fixation done elsewhere with a dislocation. You can see it is hanging on from one end, but the other end has given way. So this is a dislocated SF IOL, and I'll just show you the video. It's challenging. I'm sorry, but this video is not playing, but it's quite challenging because the IOL is hanging with one end is loose. And I was able to just remove. It was actually stuck in the area of the vitreous base, so I had to do removal of the vitreous near that particular haptic, and then after cutting the suture which was holding it onto the scleral surface, and I allowed it to fall back, and then made new ports and new points of fixation where I again resutured the same IOL. So this was what it looked like post operatively. Thank you.